Hello, my name is Claudia Habel. I'm from the Joint Action Health Information. I will be your moderator today. Hello to our session. It's about leveraging evidence for policy development and health intervention. It's results from the European Joint Action Health Information. Before I explain, very complicated, what is the Joint Action Health Information, I would like to show you a video. Please.
Amounts of health information are being collected, processed and used. There are many kinds of health information: insurance data, vital statistics, hospital care data, guidelines and manuals, big data, disease registries, indicators and survey data. Collecting, processing and use of health information in Europe should pulsate with connections, constant data sharing and new findings. But there is no infrastructure connecting health information sources or health projects and initiatives across Europe. As a result, huge amounts of health data and related information are not efficiently organized, leading to dispersed knowledge, incomplete data and difficult access. Our aim is to connect the different sources of health information, projects and networks into a European health information research infrastructure. This infrastructure will provide and share quality data, information and tools. Strengthen and promote research and scientific knowledge, cooperation and integration. Support expertise and innovation. And inform health policy. Our mission is to connect and advance comparative health research for well-informed international decision-making. Our vision is to create a sustainable infrastructure for the best health knowledge, improving population health and care in Europe. Join the European Health Information Research Infrastructure.
Thank you. So I see you saw now more about the Joint Action Health Information. All the speakers you will follow now are members of this health information group. And I have the pleasure to give the floor to the first presentation with the title Generating Knowledge on Data Collection Methods and the Availability of Health Information in Europe. The speaker is Dr. Bridget Anim. She's from the Department of Cardiovascular, Endocrine, Metabolic Diseases and Aging at the National Institute of Health in Rome, ISS. I think most of you will know it because I guess a lot of Italian colleagues will attend now. So Bridget, please show your presentation. Thank you.
Thank you, Claudia. So good afternoon, everyone. I'm going to present the results of the study on generating knowledge on data collection methods and the availability of health information in Europe. So as we know, data collection methods, metadata reporting standards, and usage of data for health monitoring and health system performance assessment are not uniform in Europe. Moreover, there are lack of infrastructures for health data sharing in Europe that limits data usage and comparability within and between countries. Therefore, the aim of this study was to summarize health data collection methods, quality assessment, availability, and accessibility procedures for different data sources used in health monitoring and health system performance assessment. We used a multidimensional approach that included review of institutional websites, such as OECD, Eurostat, and WHO Europe. Then we carried out a review of European research networks, for example, ECHO, ECHIM, Europeristat. And finally, we carried out a multinational survey addressing epidemiologists, researchers working in national health and institutes and research institutions and universities. The survey also addressed health data managers and researchers that played leading roles in European projects. The pilot phase was carried out in February 2019, and the final version was distributed to all IMPACT participants, and we asked them to share the questionnaire with their colleagues. So we use a snowball recruitment approach. So the questionnaire was composed of five main sections. In the first section, we collected social demographic characteristics of the respondents. The second section collected data on background information of the project of the study. For example, title, the country, the main objectives, main diseases, and so on. The third section was on quality assurance procedures in data collection. And we analyzed the project according to the 10 dimensional measures used by Eurostat. For example, relevance, accuracy, timelines, punctuality, comparability, and so on. The fourth section was on availability of data, and we assessed the availability of micro or macro data or other formats, and the availability of metadata. The last section was on accessibility, that is the physical condition under which users can obtain the data. So we collected 91 projects from 18 European countries. The respondents are mostly affiliated with public health institutes and universities. Most projects are representative at national level, that's 45. 20 projects are representative at regional level and 26 at both levels. The main objectives of the project were elaboration of health monitoring indicators, such as prevalence and incidence, and also health data collection. The main disease or health topic were non-communicable diseases and healthcare utilization. Regarding data sources, the most common data sources were population health interview survey, medical records or clinical data registries, administrative data, and electronic or health records. The most used data sources were administrative data in 52 projects, and the collection period was usually continuous. The collection period was continuous for electronic medical records, for registries, and it was periodic only for population health interview surveys. Tools used for data collection are mainly mandatory reports from data providers, followed by record linkage of various data sources and self-administered questionnaires. Information provided by the projects are usually socioeconomic factors, diabetes, BMI, and obesity. Out of 91 projects, only 30 projects share health data and information with European research networks, such as ECHIM, ECHO, Eurobureau, Europeristat, and so on. So regarding quality assurance, we noticed that the least evaluated criteria were punctuality and accessibility, while the most evaluated dimensions were relevance and comparability, followed by coverage, accuracy, and internal reliability. In the section of availability, data availability, we noticed that the collected data are stored as microdata, macrodata, or both. The available formats are usually electronic files, followed by publications, and data also available on websites. Metadata available in only 50 projects, and they follow reporting standards in 29 out of 50 projects. Of these 29, 7 are international reporting standards that are used by Eurostat and WHO Europe. 8 are national reporting standards, and 14 are ad hoc metadata standards. Regarding accessibility, data could be accessible to external users as micro or macro data. In case of microdata, they are usually accessible upon request, specific request that is followed by an approval that is granted by scientific committee or through a formal agreement between institutions. Microdata are reusable in 26 projects based on data usage license. Macro data are usually available in open access, and only in few cases a specific request was required, and the access was granted by a scientific committee or through agreement between institutions. Macro data are reusable in 15 projects. A financial charge was required in 16 projects. So in conclusion, the evidence produced by research is not always available, comparable, or reusable for research or policy making. In fact, only 1/3 of the projects share data with European research networks. Less than half of the projects follow metadata reporting standards for data description, and only 1/6 of the projects evaluate all 10 quality dimensions that are defined by Eurostat. So the findings of this study as part of INFACT project will facilitate sharing and dissemination of standardized and comparable health data collections, which are important for research and evidence-based policy making. Thank you.
Thank you, dear Bridget, for giving us your presentation and keeping the time. I haven't received any questions in the chat right now, but for me it was very interesting. But of course, I'm a member of this group, so perhaps I'm biased. The language barriers, was this an issue? Different languages or not?
No, it was not a great issue because the questionnaire was in English, so it was easy for all participants to collaborate.
I more thought that perhaps information was not shared or could not be identified because it was, let's say, in Bulgarian Cyrillic language. You know what I mean? Because you said a lot of information was not shared with research networks. Yeah, I understand it's not so easy then perhaps to share it because it's not in English. This
Yeah, it could be. Yeah, it could be one of the reasons.
Okay, so then I take the pleasure, if there's no questions in the chat I see, I go to the next presentation, which is then on the topic on the innovative use of health information in public health policy across EU member states. Our honored speaker is Dr. Romana Hanev. She's from the Department of Non-Communicable Diseases and Injuries of Santé Publique, the French Public Health Institute in Saint-Maurice in France. Please, Romana.
Thank you. Thank you very much. Hello, everyone. And thank you, Claudia, for such a nice introduction. So the study which I'm going to present was conducted under a work package which was focused on innovation in health information for public health policy development. And as you have seen the video, so this work package is part of the INFACT project, which is a joint action of member states to establish a sustainable health information system. So before I start my presentation, I would like to highlight some important aspects in context of this study. So there are four important points. As you are aware that over time, there are many data sources as available, such as health surveys, disease registry, administrative data sources. Some are related to health and non-health. And recently, big data is in a big discussion. So they are increasing over time. And second aspect is that with the use of new technology of linking these data sources, it make it more feasible. And the third aspect is that this linked data has a major advantage which provide a more complete information on the determinants for the population health. And it also helps to follow a large population to study the evolution of different diseases over time. So as you know that health information systems are different in all European countries, and the concept of innovation is perceived differently. So it was challenge for us to define what is the innovation in a general concept in context of public health research. So we use this definition as innovative use of data sources, as the use of data linkage and or use of artificial intelligence, which could help to understand the population health and also to promote the efficiency of health system, and this could provide guidance to make more efficient decisions for the policy making. So this study has three more specific objectives. First was to describe the use of data linkage and artificial intelligence in routine public health activities. Second, to identify that what are the different health outcomes indicators are estimated using data linkage. And third, to identify what are the main obstacles in linking different data sources. So to achieve these objectives, we designed a cross-sectional survey, and this survey invitation was sent to 31 different national public health and statistical institutes across European countries. And as you know that there are different different level of using data technology and artificial intelligence. So then we decided to present our result under three main categories. First, that's advanced, about those countries who are using these techniques in their routine public health activities. Second, who are in progress, meaning they are trying to develop these technologies and to integrate in next coming 3 or 5 years in their public health activities. And third is that who haven't perceived or planned to use these technology for their public health activities. So this survey has a quite good response rate, almost 94%. And the first part of these results highlight the current status of using data linkage and artificial intelligence. As you can see in the table that majority of the countries, they use data linkage in their routine public health activities and using it in estimating different health indicators. On other hand, the using of artificial intelligence is not common, and very few countries they have achieved this level of advanced level, and many they haven't yet decided or planned to use these technology in their routine public health activities. And the second part of the results was the different indicators which were identified by different countries. In total, we identified 107 indicators which were estimated using linked data and artificial intelligence. And we classified these indicators into three main categories. First, health outcome indicators, second, health determinants, and third, health intervention indicators. And for example, for the first category, we further classified health outcome indicators under four subcategories. For example, health characteristics, which includes prevalence, incidence of different diseases, and mortality related indicators, and some indicators related to human function and quality of life, and the fourth, some life expectancy and well-being. So according to different types or different definition of indicators, we classify them into different categories. The third part of the results was about the main obstacles which different countries identified, linking data sources and artificial intelligence. So we also classified into four main categories. So first was related to legal aspects. So in under legal aspects, so the main obstacle was the complex laws and data protection regulations which hinder to link different data sources and also to make difficult to access different data sources. And the second was the technical aspects, and many countries identify that the lack of human resources and also lack of skills to link different data sources and to use artificial intelligence for population health is their major limitations. And the third aspect was the data governance, which highlight the need of a governance health information system in a country. The fourth aspect was the organizational and structural related, and some countries they highlighted that they need more resources from different ministries which could support the health information infrastructure. So then based on these different obstacles, we proposed some recommendations according to each category. First, to improve the access and to improve the linkage. So we propose that more flexible data governance framework is necessary, and also to harmonize the GDPR regulations across different countries is really important. And second, to improve the technical aspects, the more collaborations and partnership is required, so people can share different methods among different institutes. So this will help to improve their technical capacity. The third was to the data governance, and we highlighted that the national health information infrastructure should be strengthened to strengthen the overall data governance framework. The fourth is to under the organizational and structural aspects, and we recommended that the more support should be provided from Ministry of Health and Ministry of Research for the development of an integrated health data hubs, which could be linked with different countries. So these were the main recommendations we proposed. After that, yeah, so the main conclusion of this whole study is the three main conclusions. So first was that majority of the countries, they use data linkage for their routine public health activities, but very few are expert in using the artificial intelligence. And the second important conclusion was that a sustainable national health information and a robust data governance framework is really essential, which could support the evidence-based policy process. The third is that there is a need to build a strong analytical capacity and raising the awareness for the added value of data linkage in different public health institutes. So this work has been published as well, and if people are interested, so they can read it more in detail, the whole information about that. And we thank you all our INFACT partner who contributed to this work. And yeah, so if you have questions, please go ahead, welcome. Thank you.
Thank you very much, Romana, for this nice outline. And indeed, we have received a question regarding your presentation. I will read it to all of us. So the question was, how do you deal with different institutions having different data sharing standards?
Yeah, it's a very important question. I think for that reason, there are different interpretation of GDPR regulation in different countries. For that reason, we propose that somehow these regulations should be harmonized in different, I mean, same in different European countries. So then this could be making easier how the data could be shared. And of course, the privacy is the most important aspect. So, but the thing is that right now, many initiatives are ongoing regarding establishing the health data hubs. So, so for that reason, I think this will promote the sharing of information for research purpose and for policy development. So hopefully that's the future. So people are working on that, and we have proposed these recommendations that harmonization of GDPR should be implemented.
That's fun that you say that, but of course it's a regulation, so there should be a harmonized approach already. But you're right, there is a big initiative also. I think the colleagues of Nivel are doing an analysis of how GDPR standards are interpreted or being lived in the countries. And I think also in the new joint action on health, TEDAS, which is
right.
TEDAS, I think it will be also a major topic. You're totally right to point to that.
Right.
Thank you very much for your time. I will call up now the next presentation, if I may. It's prioritization, health information in Europe. What do we want and need to know? It's presented by Angela Fair, a German colleague of the Robert Koch Institute in Berlin, Germany, from the Department of Epidemiology and Health Monitoring. But I think you changed recently, right, Angela? So you explain yourself, perhaps, please, before you start your presentation. Thank you.
Thank you very much, Claudia, for this nice introduction. Indeed, I would like to start with thanking everybody who contributed to this project, because as usual, I'm just presenting the work of a lot of dedicated researchers and team members, a core team at Robert Koch Institute, additional participating researcher, and also the review team that accompanied us with very valuable advice throughout the development of the project from the INFACT team. what I would like to present to you today is the aim and the research questions that we have pursued. Take a look at the method that we applied and show you first results. We are still a little bit in the process of analyzing the results of the study, so this will be a status quo. And lastly, give you an outlook on the next steps that we plan to do with the results that we found. So on the aim and the research question, what we would like to look at is really the process that takes place before data collection, before indicator definition, and that is the process of health information prioritization. We were interested to learn how these processes take place in the different INFECT partner countries. Who is involved in the prioritization and the selection of the information that we really want to know to firstly support existing public health issues, but also point to emerging public health issues that policy makers should become aware of. So we were curious, are there predefined criteria that the countries work with? Are there national or international frameworks? How do they include stakeholders in the process? Are there maybe any other factors? And then with a group of experts that took part in this study, maybe come up with some type of good practice approaches to prioritizing health information. So this is a brief look at the timeline of the Delphi survey. It started with the start of the project about 2 years ago with a literature review. And the Delphi is organized in, or was organized in 2 rounds. In the first round, we had structured and semi-structured questions. From the semi-structured questions, we did a qualitative analysis so that these could be transformed into structured questions for the second round. In the second round, we asked the experts to rank the different concepts according to desirability, feasibility, importance, and confidence. This is the concept of the so-called policy Delphi. Maybe just a note on the policy Delphi, it is not an instrument to achieve consensus, but to present a variety of options and have experts rank these. We have just finished the analysis of the second round, and we are still in the process of doing the final analysis. And the overall aim is to develop a guidance, like maybe a good practice for health information prioritization in close collaboration with all the INFECT partners and the steering group. So the first sample, we received 19 fully completed questionnaires and also some answers from interrupted questionnaires. You will see that later, that some of the questions we will have a higher total than 19, and we included the interrupted questions. The second round, in fact, it fell right in the middle of Corona, and so participation was a little reduced, and we're very grateful to those partners that did respond despite the overwhelming work in the Corona pandemic. Of course, we wanted to know a little bit about the background of the different participants, and you can see here their affiliation, and what was particular of interest for us was their degree of involvement in health information development, because that would give us an idea of the expertise that the participants bring into that study. And we were very glad to learn that you can see that here, that mostly showed very high or high involvement in health information development in both rounds. Here in the first round, we asked whether structured processes exist at all at the different national levels in the countries to prioritize health information. And then the second round, we looked at the different processes that we received as full text replies. We developed concept from them and put them to a ranking. And in terms of desirability, the participants in the second round informed us that the horizontal approach that includes stakeholders and experts to develop priorities is the most desirable function. In terms of feasibility, it seems that a top-down approach where government sets the priorities is actually the most feasible, in fact. Looking at stakeholder involvement, we asked the participants whether stakeholders are involved, and 65% said yes, they do involve stakeholders, and there's a large list of potential stakeholders that are included in the prioritization process. And the most desirable for all of the participants was to have national public health institutes involved, also regional governments, highly desirable and desirable. And so there's very few, actually only health insurance companies and data collecting institutes that received and the vote of undesirable as partner in the development process. In terms of feasibility, it's a bit different. National Public Health Institute is very easy to have them involved, but for other partners on the list, there seems to be some uncertainty of how to involve that, and we will look further into that barrier of involving these partners. In terms of criteria development, we were interested whether the prioritization processes followed criteria. And so this was the question in the first round, and you can see that on the left side, that 55% in the first round said yes, they did follow criteria. And they gave us a number of partners that they think should be involved in that process. Also, again, the question about the participatory approach. Mixed meeting researchers, policymakers are the most desirable group to be included in that development of criteria. The most feasible option was expert consultation via email, and data analysis or expert consultation via email, however, was also received some undesirable votes. So there's a mixed reply. And again, we would have to go into more detail, especially in terms of feasibility to see where there are barriers to participation for partners, especially that are considered to be desirable or very desirable to be included in that process. Frameworks, that was another question that we were interested in how far national or international frameworks guide a prioritization process at national level. International frameworks such as WHO action plans or international regulations, or at national level then national health targets, for example. And the overwhelming majority in the first round said that these frameworks, national or international, in fact, do guide national prioritization processes. And in fact, of interest was that in terms of feasibility, it was only the global burden of disease studies that received one vote of being possibly unfeasible to be included. And that, again, we will explore in the continuity of the process to see where there it seems to be a difficulty. In terms of desirability, all the different frameworks that were mentioned seem to be highly desirable or desirable as guiding factors for prioritization. And these also were seen as very feasible or possibly feasible to be followed. And last but not least, we asked about approaches to good practice, whether in the different countries there have been taken approaches to good practice in prioritization. And the most desirable seemed to be to implement a national health information strategy. The most feasible was the implementation of national health targets. Scale up topic and disease-specific good practices was also desirable and very desirable, meaning that the approach from a more sector-specific or indicator-specific approach that could later maybe be merged into a more overall strategy. Look at the time. Lastly, we asked the partners what they think could be processes to promote good practice in health information prioritization at the EU level. And it was the cooperation at the level of supranational organizations, let's say EU, OECD, and WHO, to develop joint information methodologies that were highly desirable. There was nobody who said that it was undesirable or unfeasible. So this is the approach that the partners wanted to take. On the last slide, the next step, we will now continue to final the data analysis, and from these final data, draft recommendations for health information prioritization, present these to the INFACT partners for review, prepare a set of finalized recommendations. All these will go into the final report of the project, and we also strive to include it in a publication. Thank you very much.
Thank you, Angela, for the presentation. I see there's a question, but I think the question is still for the previous presentation of Romana, or for all of us basically, because the question was that the GDPR, so the General Data Protection Regulation of the EU, is a bottleneck, particularly its different interpretation in different member states. I would envisage a study to highlight what main differences are and what problems these specifically produce. So this question, I think I can answer easily, because I tried to point out that the commissioned the contractor to look into this question exactly. I think it's at least aided by the Dutch Nivelle Institute, and they prepared, they do a big survey currently among all the member states and authorities being in charge of data protection in a country. I know that very well because I was one of the respondents of this questionnaire. It's a hell of a job to analyze this, I'm sure. So this study is being undertaken, and I guess the timing is that it will be published earliest end this year, to my knowledge. So I hope this answers the question from the chat. I don't know if anybody of you wants to add something here. If yes, I think it's best you raise your hand, and then the technician gives the floor to you. No? If not, then I'm happy to hand over to the next speaker on our list, which is for the topic of real-world evidence for European health policy making the case for interoperability. The speaker is Enrique Bernal Delgado. He's from the Health Services and Policy Research Group for the Institute of Health Sciences in Aragon, Zaragoza in Spain. So please, Enrique, floor is yours.
Thank you. Thank you very much, Claudia. Thank you to you all that are present here today. Well, let me first a bit of contextualize my presentation. This is, I think we are all witnessing a knowledge paradigm transition, or maybe a tension between knowledge paradigms. That this is actually behind what we are trying to do in INFACT, to join action. Well, what is this tension is about science world evidence and real world evidence. Science world, I don't mean that the scientists are not in the world, but many times we are on the moon. So the point is trying to make what we do, compatible with what is needed by policymakers. So, and this is the point about real world evidence. Let me go more in depth on what I mean. Well, this is the traditional approach from science. It's legitimate to ask ourselves as scientists if this traditional approach is well equipped for policy decision making. And many times what we see, most of the research we've done in the past and we are doing currently is actually partial, is trying to respond to specific questions in rather controlled conditions, not truly looking at real population or real patients because of the controlled conditions that we have to develop. The context where these populations are observed or patients are observed are quite different to the context where populations and patients are actually living and for which we are supposed to provide outcomes. Usually the research results are belatedly reported, many times, most of the times, we are not able to evolve the results to include new samples, new patients, new populations, new cohorts. So we are not able to provide up-to-date information, and rarely all what we do is embedded in the real decision-making processes. At the other side of the tension is the real-world evidence approach. And this, again, is a legitimate question for our side, is asking ourselves if real-world evidence approach is better equipped to inform decision-making, policy decision-making everywhere. And well, the point, maybe the virtualities of this approach is that actually real-world evidence taught us about real populations and patients in real contexts that are evolving, by the way, constantly. We are able to look at those real exposures, the real risks, risks that happen in reality. Information systems capture, and we are in Europe, we are very well equipped in that sense, because the information systems are widespread in all the countries, are capturing almost on-time information on the individuals and population exposures. And those information systems are actually conceptually developed to inform decision-making. Well, so I tend to say I'm positive on the fact that real-world evidence might be better equipped than science-world evidence to produce this kind of relevant, meaningful research outputs for policy decision making. But, and this is a big but, what happens is that if we are to use real world evidence, we have to face very big challenges. The big one is the high volume of data, sometimes huge, massive data that we have to manage. On the other hand, there is another challenge, of course, I would say, that is the data heterogeneity across data sources, across countries, across data hubs. Then the data are continuously evolving. So you have to take into account this evolution when you analyze this real world data. They are produced at different velocity. Some data sources produce data in a daily basis. Some other data sources produce data in a yearly basis. A big one is big challenge, different semantics. Many times we are not talking the same language across data sources, even within the same country. And then the uneven quality of this data that are produced this way. Then, for example, we do misinformation in the patient follow-up, or we may have registers that are incomplete or maybe biased. So many challenges, although apparently real-world evidence might be better equipped. And another reflection on it, how we are able, and this is part of the actual, underlying big question for impact, joint action. How are we able to generate real-world evidence for European policymaking in this Babel tower of so many languages, so many data sources that so nicely have shown us Bridget, Angela, and Romana? Well, the option for INFACT was to deploy a federated infrastructure, data infrastructure for policy-oriented research. Well, there are many other architectures of a federated infrastructure, but given the uneven level of maturity across countries in Europe, we end up deciding for this kind of federation, where there is a hub, this nice lady at the top, that actually is acting as the coordination hub for the whole federation. And there are many other hubs that are actually, data holders. So institutions then either own the data or maintain the data or curate the data. But also research is in there. So this is the kind of mixture of different data hubs, data research institutions in Europe, and someone else that is coordinating the whole thing. In fact, we have piloted this kind of solution. And with a view of, I mean, we were commenting earlier on that one of the big hurdles for the development is actually data sharing. So one of the beauties of this approach is that data remain at home, remain in house, remain in the data hub owner. So we are not moving data. What we are moving is communication. And I will explain later on. So let me go a bit in depth on this. Well, this is the in-fact solution, but there is a prerequisite for a federation. So you have to talk the same language, which is impossible a priori, but you have to develop interoperability at different levels. This is coming from the European interoperability framework, where they describe 4 layers of interoperability. The legal one, which refers exactly what you were mentioning about GDPR, and the implementation in GDPR at different institutions in the different countries in Europe, but not only, because also there is legal provisions within each organization. Organization interoperability, which means in the end, how we made decisions with this federation. So we have to agree the governance model for that federation. So imagine that there are people that are actually leading data institutions, data authorities in there, for example, the National Institutes of Statistics, along with others like hospitals that are actually collecting the data for patients. So this difference is obliged to have a good governance of any federation. Then a third big hurdle and interoperability point is about semantics. So what is the language we are going to understand each other? And you have to deploy a number of activities to reach interoperability in semantic terms, and then technical interoperability, because the developments are uneven and many times different across the different data holders. We have to be able to connect at some point, the different technological systems. So when we try to deploy a federated infrastructure, to pilot, better said, a federated infrastructure with an in-fact in action, we had to take into account these 4 layers at some point. Let me go to this. This is like one of the case studies that we have actually piloted in the federation. We have been using three different case studies. One on the development of a monitoring indicator for healthy populations. A second one on dementia, healthcare utilization and costs, and a third one on real-world evidence on stroke care. So this is the small example that I'm going to give you today to illustrate a bit what we have been doing in InFactor in action. Why 3 case studies? Because the level of granularity and the number of data sources to be used are different. And then we departed from a simplistic exercise on health monitoring to a more complex one, which is this one that I'm presenting to you today. So what you are seeing there, or you have seen already, these ones are actually patients moving across the system. So we were able, in a previous pilot, to actually know what happens with the individuals that suffer an ischemic stroke in different providers in Aragon, in our region here in the north of Spain. So the question was, will we be able to deploy this exercise in the different nodes, in the different data hubs, in different countries in Europe, using this federated infrastructure? So are we able to use real-world evidence to inform at some point decision makers on how to proceed with this type of patients? So to do so, these are the steps to deploy a federated infrastructure. Beforehand, we need to have clear what we do need to ask to the data sources in place in each country. So beforehand, we have to to design what we call it a common data model. So the logic of analysis, how we are going to ask to the data sources about the problem of interest, in this case, stroke care. The second point is once we have this, then we have to pay attention to the different languages across data sources and data hubs and build a layer on semantic interoperability using the coding systems, WHO coding system, national coding systems, or other layers that are actually in place. For example, OMOP is one of the layers for semantic interoperability. The point is that, yes, talk the same language is the only idea. Once we have that, and this is one of the beauties of this federation is, well, I say to you that we are not sharing data anymore. What we are sharing is a communication system, which are the shared scripts, the software scripts. Once we have clear that the data have, a fair quality, then we share scripts, we share softwares from the central coordination node to the different data hubs. So instead of the usual way, moving the data from data holders to a central repository, what the different data holders are doing are replicating the analysis using these scripts that you are seeing on screen. And finally, you have to run the scripts yourself in-house to produce the same kind of spaghetti graphs that you saw in the image before. So running the scripts locally and then share the results for meta-analysis in the central repository. These are necessary steps. If you allow me, this is my last slide. These are the lessons in this 2-year process we are following. In a federated research infrastructure, don't forget it, data remain in-house. But research questions, data access, and interoperability services are shared. So you need a lot of, a lot of effort in this share. And this share implies governance procedures to make decisions on safe data motion, so following safety and privacy by design, the provisions by the GDPR, but also by the Helsinki Declaration, governance procedures to establish the different roles in the federation, who is doing what, when, and why, development and maintenance of the common data models, because this is the key point for interoperability, development and maintenance of the analytical pipelines. Those software scripts have to be maintained, improved, because many more other research questions will come up in the future. Then build capacity. This is a critical point to get all hubs fully involved. It entails not having huge servers to move, the huge volume of data. Is more about personnel. It's more about technical skills that data holders need and data hubs need to actually deploy the scripts in-house, and then secure the evolution and sustainability of the federation. So meaning the upgrade of the federated infrastructure in the future. So thank you very much, all, and I'm completely open to your questions. Thank you.
Thank you, Enrique. And indeed, some questions have reached us. I read them to all of you. So the first question was, what then do you consider as a good practice? So the purpose is to have interoperable health information. So in my view, a good practice is according to this. What is it about? Huh? So what would you say is a good practice for sharing? Is the question.
Well, a good practice for sharing comes out of this first decision in how this federation is governed. Once the different hubs make a decision on how to manage, then and it's agreed, then everything flows smoothly. So the very first point is about agreeing on the governance. Of course, you have to be compliant with GDPR with your own regulation and so on and so forth. But this is, let's say, given by fact. It's not new. So you have to make decisions first on how to govern. Then there will become the technicalities. Everything has been discovered, let's say, at this point. So technicalities about how to develop common data models, technicalities about what are the kind of mathematical analytics that you need to do the research, or what are the best software or the best hardware technologies that you have to use to deploy the federation. But the very first thing is making decision on how to govern the infrastructure.
Thank you. Yeah, I would agree that the willingness is the most crucial thing to get things, to move things, and in which direction. And the technical solutions, I think, are the easier part then.
Yeah, absolutely.
Compared to the political decisions.
Are instrumental, yes.
It's sad. Well, the reason is sad, but still, I think the corona situation all decision makers are faced with, they give them a very good impression why such databases and such shared infrastructures are necessary. I think this is a boost in needs. Yeah. So yeah. Sorry to say, but this is perhaps the sole good thing that comes out of this crisis. Actually, there's another question. I also will read it to all the delegates, and it's directed to you again, Enrique.
Yes, please.
So the next question is, the delegate that has asked it sees a problem. The development of technology makes it possible increasing of entering into the data circle ever new data sources, as well as increasing the resolution of existing data resources. So how would you manage this problem?
Well, this is actually when you build the big point here is building the common data model for as many research questions as possible. Because when a new data source comes in, then the only thing that you need is to look at the link. What is the main entity for public health research that you have to have in a common data model? The individual. What is the second main entity? The place where the individual lives. So the point is, if you have a new data source with the individual pseudonymized, it's not possible to use it non-anonymized or not pseudonymized data. If you have the individual identified and located in a specific location, then you can link it to the previous data model. So you can increase the amount of data. So you can then make it incremental, which is the point. So part of the sustainability, of this kind of federated infrastructures comes out of the fact that when you have decided the common data model in a way that is incremental, you can add data sources from any country to join, or data sources from any researcher to join, or from any data holder to join. This is the big point.
I understand it's more or less the data model is very crucial. So if there's a problem or some mistake in the data model itself, then so the generic data model, can we say, so then we will struggle with that all the time, right?
Yeah, actually, the best option would be to have a common data model for any kind of question of interest. Many times is that not possible. You have to build, data models that might respond to a big number of questions. And many times you have not the opportunities. You have to build, separated data models. But in any case, whether it's general or it's specific, you need a common data model.
Okay. Thanks. I hope this answered the questions that were put on the chat. There is no more for you. So I thank you very much, Enrique, and I'll give the floor to the next speaker in our order, which is on the topic on Health Information Impact Index, which is a new tool to monitor the uptake of evidence in policy and practice. I think it's a very interesting topic. It's presented by Dr. Marie Del Nord. She's working in the Department of Epidemiology and Public Health in the Belgian Public Health Institute, Sciensano. Please, Marie.
Thank you, Claudia, for the introduction. I'm happy to share with you some of the results of a postdoctoral project that took place over the past 2 years in link with INFACT. So the focus of the postdoctoral project, which is a Marie Curie Fellowship, was on knowledge translation. And I was able throughout to have some feedback from my colleagues here and also the overall consortium of partners in the different countries that are participating in INFACT.
I'm sorry to intervene here, but Marie, we can hardly hear you, at least myself. I hope it's better for others.
All right. Is this all right. So the main objectives.
Much better. Thank you.
Okay. All right. So the main objectives of the postdoctoral fellowship were to, one, better understand the mechanisms that drive the uptake of evidence in policy and practice, and two, to also provide an evaluation framework for monitoring the impact of health information systems. Because the heart of the question for this project was to really understand and have insight on how do we know that evidence actually informs policy. So when we know that we have the data providers on one side, which are within the health information system, so these are going to be the different public health agencies, the different data sources that are used in the country to generate evidence at population health level. How do we know that the evidence that is generated from the system actually penetrates the policy and practice process and is used for decision-making and intervention? So is there a way that we could a little bit standardize the criteria that accompany this process from data generation to data use and intervention in the healthcare system? So we developed a conceptual framework for monitoring the impact of health information systems in policy and practice. This is a study that was published in the European Journal of Public Health last year. And for the study, what we did is that we did a scoping review of knowledge translation frameworks that were published between 2008 and 2018. So we did a scoping review versus a systematic review. A scoping review is used to really map the outlines of a concept that is still in the making, whereas the systematic review will look more into synthesizing the best available evidence. For the scoping review, we focused on knowledge translation and seeing how it has been defined in the different health settings. So whether, how has knowledge translation been defined for healthcare compared to health policy or in community health? The conceptual definition is that knowledge translation is known as the appropriate exchange, synthesis, and ethically sound application of knowledge to interventions that strengthen the healthcare system and improve health. So what we did is that we were able to include 79 knowledge translation reviews in our study, and we did a thematic content analysis looking at each of the reviews and seeing what were the mechanisms that they identified to illustrate the concept of knowledge translation, and also what were the determinants that facilitate or actually hinder knowledge translation and evidence uptake into practice. So some of the frameworks were developed specifically in particular areas of health, such as cancer research, child health, or healthy aging. But what was noticeable in the scoping review is that none of the frameworks were actually directed for use at systems level. So considering that in the health information system, we have a fragmented data landscape with multiple actors that are involved in generating health information, how could we develop one common framework to look at systems level, the uptake of evidence into policy and practice? So one of the key findings from the study in terms of commonalities is that across frameworks, it was very clear that their knowledge translation is seen as a cycle, and also that there are two stages, the first being data production, but then the data being analyzed and reported to end users, so this constituting the dissemination stage. The evidence is then used for decision-making by the relevant stakeholders, whether it is for deciding on piloting a specific intervention in a setting or adapting an existing intervention into another setting, or for use in policy. So this constituting the implementation stage. There is also continuous feedback between the dissemination stage and the implementation stage. What we did also, so based on identifying the process for knowledge translation, we also looked at the different barriers that researchers or public health agencies or the health information system as a whole may encounter when trying to leverage the evidence for decision-making and intervention. And what we realized is that there are 4 key domains that are really critical to monitor the impact of evidence and policy and practice. And these domains constitute the health information impact framework. So the domains actually, what is interesting, echo some of what's been brought up today in our discussion in terms of making sure that there are quality assurance procedures in place, in terms of stakeholder involvement, also looking at how do we capture new types of data sources, include them also in the evidence use process. So the 4 domains, the first one is that we need to make sure that health information and evidence is of very high quality. So we want to know that the evidence is reliable and also fit for use in decision making. This is really the baseline, I would say. The second domain, once we know that at health information systems level, so at country level, in a sense, we want to make sure that the evidence provided in the health information is disseminated and also easily accessible to the appropriate stakeholders. The third domain that is critical to look at is once we've produced high quality data that it can be accessed by stakeholders, we actually want to monitor how are stakeholders engaging with this evidence. So what decisions are being made, what type of stakeholders are using what type of evidence. So this is really looking more into the interactions between the evidence produced and then the decisions that are made. The fourth domain is knowledge integration, because when leveraging evidence to have an impact on health outcomes, we want to know also beyond the health system or beyond the health sector, how is evidence being leveraged and used also in civil society, and how are other sectors mobilized with the health information available? So this is more looking into the reach of the evidence generated. So the Health Information Impact Index, so this is a tool that was developed based on the Health Information Impact Framework. The aim with this tool is to capture more systematically what happens next, basically, when evidence is delivered to decision makers. And we developed a list of 30 criteria to monitor routine health information availability, dissemination, and use. In order to develop the index, we used a participatory approach. So we used a web-based Delphi that was held from February to April last year. The Delphi process is what we discussed it a little bit in the previous presentation with Dr. Angela Furr. So it's an agreement process that is based on priority ranking of different criteria. Here we used the criteria from the scoping review that we did prior to the Delphi, and the different criteria were presented to a panel of experts. They were then invited in successive rounds based on the relevance of the criteria and feasibility to decide which should go into the Health Information Impact Index. So we contacted nearly 700 European public health professionals and policymakers, and participants came from 38 countries overall. So we had 3 rounds of priority ranking for the criteria with around 150 to 220 participants per round. Most of the participants were doing research or in academia or teaching. And then in health statistics and quality assurance, we had less participants coming from the policy side. So now I will present, so I said that there are 4 domains in the Health Information Impact Index, and I will now present the results of the Delphi and the criteria that were retained by the expert panel. So in the domain of quality, there were 6 essential components that should be discussed when considering knowledge translation. The first is that the legislative framework that is operating at national level should support the collection, processing, and production of health information. So this is looking into what are the right resources available to actually produce high quality information. The second criteria looks at whether or not health information is representative of the general population. We want to ensure that there are high standards of reliability, transparency, and completeness. And this is whether we are speaking about aggregated type of data or individual level data, or also new types of data that might be coming in. The fourth criteria is looking at whether trends data is available at population level. We also want to look beyond the trends and also see if we can actually use the evidence by clinically relevant subgroups or major geographical or administrative regions as appropriate. This will help in terms of use for policy, because policymakers will be interested also in implementing targeted interventions in specific settings. So we want to make sure that the evidence that is produced actually allows that to have that level of granularity that will be relevant for intervention. The sixth criteria in this domain is looking at whether the different health status and health system performance reports are actually published annually and on a regular basis for stakeholders. Now moving on to the second domain of the index. The criteria here essentially look at how evidence is being accessed and is made available to the stakeholders. So I won't go through the whole of the different criteria that have been retained, but essentially what you need to, what I would like to share is that one criteria is whether or not health information is available very widely using several formats, several communication channels, whether also there are any barriers in terms of having to pay perhaps to access certain types of microdata, or whether there is an administrative burden that is perhaps hindering access to information. This is something to consider at national, regional, or local level when considering the impact of your health information system. Another thing that came out from the Delphi is that the experts agreed that data should be fair within the different data sources in the health information systems. The FAIR data principles were developed in 2016 by Wilkinson et al. And these basically promote the dissemination of findable, accessible, interoperable, and reusable data. So these concepts have actually also, this is a little bit of what we discussed in the previous presentations in terms of interoperability also, and reuse of microdata. The last point for this domain that is particular is also that the experts believed that the evidence and the health information, whether it's provided, for instance, in a publication, there should be actionable recommendations also included with the data. So moving beyond just providing quantitative information, also having some level of interpretation and policy options for decision making. For the third domain of stakeholder engagement, here we are looking at what the decision makers are actually doing with the evidence that is provided to them. Some of the components that were important for the panel in terms of monitoring the use of evidence is whether or not this evidence is used for reducing inequalities in health or healthcare. It was also important to consider where the evidence is used. So in what sector? Is it in planning and policy? Is it for resource allocation? Is it at the level of administrative offices or by care providers? It was also important for the panel that in the index, we included criteria on the actual decisions. So beyond just informing the process, can actual decisions be traced and linked to specific types of health information outputs that have been provided? So whether these are public health reports or evaluations from health promotion campaigns. The last point in this domain is also important to assess and consider whether or not at health information systems level, we can say that the recommendations from the different agencies and academia are included and guide the priority setting process, not only for health information, but also actually for intervention. So again, looking at the use in several stages and at different layers. The fourth and last domain is knowledge integration. So the criteria here are more high-level criteria that can be used at systems level. So this is looking at whether or not, just as a reminder, how far is the evidence being used across sectors. So one of the important criteria for this domain is looking at whether the government actually publishes an explicit plan for health in all policies to facilitate the use of evidence in other sectors as well, not just in the health sector. The second criteria looks and monitors whether or not there is regular conversations between the public health agencies, the ministries of health, and also perhaps other ministries that might be relevant to engage on specific health issues. The third and fourth criteria in this domain look at the use of health information to advocate for health equity. So how are we mobilizing also civil society with the recommendations that are coming out from the public health agencies and the other actors in the health information system landscape? The last criteria in this domain also look at whether or not evidence can be used to impact on the social determinants of health. So when we're considering, for example, prevention for cancer, are we also tackling at some of the underlying determinants through the evidence that is provided? And also considering health literacy and whether this is something that is pushed and encouraged within the country. So this is my last slide, just to summarize a little bit the added value and some of the main strength of this index is that the Health Information Impact Index is a new tool. This is a new tool that was developed based on the concept of knowledge translation and scoping the important determinants of knowledge translation. The focus on knowledge translation actually expands the scope of current health information system evaluation frameworks, which have so far really focused more on quality and data production aspects. And this tool could be used by European public health agencies to monitor the impact of their information products, and also just to start a conversation among key partners and agencies on the promotion of evidence-based public health. Thank you.
Thank you, Marie. We have to look a bit at the time, so just I got questions for you, so please try to answer them in a concise and brief way. So the first question was, so if you did not look so much at the health information, let me check, why you left out the health insurance in the first instance, was the question at the beginning of your presentation. And the second, or will you reply now to this one?
So just to make sure they understand the question, so if I left out the health insurance agencies from the health information system landscape,
yes.
No. So health insurance data systems and data sources would be included within the health information system. I think this is something that, in fact, in general, we can say that for the health information system, what we mean by this is really all the data sources that are institutionalized at country level to provide evidence not only on health status, but also on the determinants of health and health outcomes. So this would include also the data that is included from health insurance providers.
Thanks for clarifying that, dear Marie. And the final question for you is, a colleague commented that, sorry, I do not see any reference to the major role of health information on costs of healthcare. Beyond the health as a public good, the cost of health is of paramount importance to the society, particularly in achieving cost effectiveness. This is missing, so this presentation seems quite unilateral, so one-sided, yes. He says.
Yeah, I understand the comment. I think this is because also looking at the impact of policy, of health information in policy and practice, this is something that is quite new in terms of standardizing and providing a framework. So far, most of the evaluation frameworks that have been developed, for instance, in the US, to look at knowledge exchange, or also with the WHO support tool for assessing health information systems, it's only been based on more of a focus on data production. So are we putting in the resources for producing the data accurately? But looking at the evaluation of impact. So looking at how are people using the information. This is almost like a second step, extending further what is currently existing. Now, what the participant has mentioned is true. Looking at the cost of healthcare, this would be actually for me a third stage. This is already looking at with the evidence that we've provided. It has been used for decision making and for intervention. Now, can we link the impact on the actual health outcomes that we're observing? And with this equation of looking at the association with health outcome would come also the conversation on cost efficiency and seeing if we can actually tie that to return of investment on investing in health information activities. So this is a process that we're engaging in terms of expanding current evaluation frameworks, and also now seeing if we can move that even further and tying it to health outcomes, and also considering cost aspects.
Thank you very much. Thanks, Marie. I will now give the floor to the next and final speaker in our round. It is on the topic Lost and Found, Enablers and Barrier of the Exchange of Health Data Across Countries from an Interoperability Perspective. Oh, you mean, okay, I think it's a misunderstanding perhaps. Can you re-invite David? The delegates, we missed our speaker, Damir, but I see him on the list. He's back. He's on the list. Damir, good you're back. I just tried to, I introduced your name of your speech and that you're member of the Croatian Institute for Public Health in Croatia. So I give the floor to you, and you see the time is running, so please start.
Yes, thank you. Can you see my screen? Good. Okay, sorry, my Zoom crashed at a crucial moment, but I'm back.
It's working.
Okay, so for the last presentation, I will briefly talk because I'm aware that we also maybe want to leave some time for the discussion on this topic, but discussion in general. So I will briefly talk about one part of work that we are also conducting within the INFACT joint action. And this is the work on identifying and analyzing enablers and barriers to the exchange of health data across borders. And this is, of course, heavily linked to all the presentations that we've seen and heard about today already, and the concept of interoperability, which is a crucial one in this work and in general in working with health data, especially exchanging, managing, and linking health data. So in the work package 10 in one part of work package 10 of the INFACT joint action, we are techniques that aid the linkage, management, and sharing of health data, and we are focusing on working with health data in a cross-border manner, so across countries in Europe. As Enrique previously mentioned, we are here anchoring our work in the European Interoperability Framework, which describes these 4 layers, which are the legal, organizational, semantic, and technical one, as well as a cross-cutting governance layer. And we are focusing our work in these 4 layers. In the work package 10, as I mentioned, we are working on mapping and analyzing these enablers and barriers for cross-border health data exchange and linkage and managing. But as Enrique already talked about, we are working on empirical case studies and on piloting such an approach to interoperability. This is then again a small overview of the work. So both the assessment part and the piloting part and the results that we are producing within the joint action, some of which are already available on the INFACT's website and some of which are due quite soon and will be, of course, publicly available. In looking at how different projects around Europe dealt with exchange of and linkage and management of health data across borders, we used this ad hoc developed framework at mapping and analyzing these kind of inspirational cases. And we looked at projects that studied these basically categories of data. So health status data, health determinants data, and health system performance data, providing insights on surveillance, impact, and effectiveness using different data sources, and working with data sharing, linkage, and management. In the first phase of our work, we've we've mapped over 100 potential projects around Europe that have exchanged health data and worked with it. And after applying these criteria, we have ended up with 59 so-called inspirational experiences, inspirational studies around Europe that we looked into more detail. For the second, and these are the projects, a lot of which I suppose are quite familiar to people working in a health information area. For the next stage of our project, we've worked on developing an interviewing instrument, an assessment instrument, to talk to as many of these projects or people working with these projects, asking them about their experience of managing and linking and sharing data across borders, especially focusing on these 4 levels as described in the European Interoperability Framework. So the legal one, organizational, semantic, and technical. We've conducted in total of 20 interviews. As I said, we focus on categorizing these enablers and barriers, and we are still in the process of analyzing these, analyzing and validating these results. And I will just briefly present some these are the projects that were interviewed and the countries in Europe that were, so pretty much a pan-European overview. The analysis was done based on interview transcripts, qualitative analysis, thematic analysis. And these are just some of the examples of the results, the final results that we expect to end up with and present soon. And for instance, talking about legal interoperability, some of the enablers were, for instance, having legal requirements for participants to these projects to report and adhere to different legal requirements, because it in a way standardizes the legal and regulatory landscape, but also barriers, as I think some of you already mentioned, some of these topics, the distinctions between anonymized and pseudo-anonymized data, and identifiability of the data, harmonization, legal harmonization in Europe still, despite the efforts. And one of the legal, for instance, barriers that was mentioned in working with health data cross-border was Brexit, for instance. In terms of organizational interoperability, we saw that giving flexibility to how processes are organized across different teams in this pan-European project works as an enabler. Also working on different research studies within these projects and publishing, and also including this educational component was a big enabler. But then barriers presented, for instance, that some services in the health sector are provided in different areas of specialized and primary care in different countries, which makes organizationally, which makes collaboration between different levels of services relatively hard. In terms of talking about technical interoperability, again, something that Enrique already mentioned, enablers using federated data systems, existence of unique patient identifiers, dataset templates, and harmonized standards and protocols were some of the enablers that were recognized. And then course, on the other side, a big barrier to technically linking data was the lack of unique patient identifier, which is still the case in some countries around Europe. In terms of semantic, again, big focus on standards and code books and definitions, and barriers being sometimes we heard about clash of different recommendations and standards, and also certain areas which lacked standards, so-called gray zones in working with data. So yeah, this is a very brief overview. We are now working on finalizing the analysis and of these interviews and validating the results through the steering group partners, steering committee partners within INFACT, and hoping to soon publish a set of results and recommendations based on this work. And as was mentioned previously, a lot of this comes down to political, legal, and organizational issues in working with health information, across countries in Europe. Yeah, thank you. That's about it.
Thank you, Damir. There was no question I got for you. I would have one, but I think the time is running a bit. So the first thing I will do is I thank all the speakers we had today, which is Bridget from Italy, Romana from France, Angela of Germany, Enrique of Spain, Marie of Belgium, or France actually, and Damir of Croatia. I think we had a good mixture. It's a good representation of our joint action health information group. Thank you all. And I just, a brief comment for your presentation, that why countries do not share in aggregate data despite they're not re-identifiable. This was quite surprising for me. Yeah. But with your, if we have still time, I think if the counting is correct, we only have 30 minutes and then we can ask anything. I'm not sure. The technician wrote me we are a bit delayed, so perhaps we can have it longer. So just Damir, perhaps you can say something on that. So why do countries not share data?
You mean the aggregate level data?
Yes.
Yeah, often this comes down to organizational issues rather than just the legal ones. So the legal framework might be there, but it might be often it's the issue, the lack of political will and
or lack of staff or so. Yes. Okay. I'm not sure if we're now finished because the counting is going down. I think you see that. Our I thanks all the delegates, all the speakers. I thank you, Marie, especially because you made this session possible. Thanks special to you. Well, if there's any more questions or regarding slides, please, delegates, contact us and we will try to give you some information. Okay, have a very good day. I think the technician will now close the session. Thank you and goodbye.